I note that this is being filmed by Pie Magazine, Australia, Asia Pacific's posterior segment magazine, being run by that guy Matt Young in the watermelon suit. So, what about steroids for retinal vein occlusion? I'll go about where this came from. We developed steroids, I think, in Sydney. The major studies here are the SCORE studies from the NEI, Geneva, these head-to-heads from Novartis, and a real-world study from Yong-Hee's group in Korea. So Philip Penfold and Alex Hunya Sr. started injecting triamcinolone to eyes with AMD in the early 90s, and we conducted a clinical trial. We didn't actually find a beneficial effect on AMD for triamcinolone. I think this might have been the first intravitreal injection study ever, but then we did the diabetic macular edema study, and we found a good result here. Over 5 years, basically, you doubled the chance of improvement of letters, vision gain, and you increased the reduction in macular edema, in diabetic macular edema. So steroids can be effective for macular edema. What about RVO? This is the SCORE study where they looked at 1 and 4 milligrams of Trivaris, which is only really used in the NEI studies. I'm not quite sure about the pharmacokinetics of this drug. And they compared this to observation for CRVO and laser for branch retinal vein occlusion. Essentially, the SCORE BRVO study found no benefit of triamcinolone here in terms of letters gained over the first 12 months, or the proportion that gained 3 lines. It was the same for laser, and because it had more adverse events, they did not recommend triamcinolone for branch retinal vein occlusion. Excuse me. However, the results for central retinal vein occlusion were much better. We had over a quarter of the patients gaining 3 lines in the 2 dosage groups, with only 7% in the so that shouldn't be good later, that should be observation alone there, which was, these vision improvements were sustained in years 2 and 3. So they did recommend that triamcinolone is effective for central retinal vein occlusion. Then we come to the Geneva studies, quite early on these studies in 2010, where they did branch retinal vein and central retinal vein occlusion with these inclusion criteria. They had 2 doses of dexamethasone and sham treatment. So essentially, for the whole group, the story with Geneva was that it worked at 3 months. These were 3-month results. They had good improvements in vision, and they had good reductions in central macular thickness compared with sham. However, at 6 months, which was the primary outcome, the drug had worn off, and there was no difference between the two, between the active and the sham-treated groups. And you can see here the mean change in vision from the branch retina, the CRVO patients, a good improvement at 3 months, which had worn off by 6 months. And then when they came and injected again, they got another improvement, and it wore off again by 12 months. You'll note here that the sham-treated eyes, when they received active treatment, they didn't catch up to the eyes that had been treated the first time around. And this is a consistent message with all these studies from retinal vein occlusion, that if you delay treatment, you pay a price and you don't get good results. You tend to lose vision as time progresses. They found the same thing here for branch retinal vein occlusion, a good improvement for 2 to 3 months, which wore off again. Now, some people concluded from these studies that steroids do not work for retinal vein occlusion, but clearly they do. They just thought the drug lasted for 6 months, and they took out the primary endpoint at the wrong time. And here again, you can see comparing the patients that had edema for less than 3 months prior to entry into the study compared to those that had for more than 3 months, showing again that the patients that had the edema for longer got the worst results. So early diagnosis and treatment is important in RVO, and this is the chances of getting a 15-letter improvement in the second treatment cycle compared with the people who had sham or got the active treatment the first treatment cycle. Patients who were treated from the get-go had a 3 times chance of, in all these, across all groups, for getting a 15-letter improvement. So what they did here, they didn't achieve their primaries. They had 2 studies. They combined the 2 studies, and they made the new outcome, without doing any further trials, the time to the first gain of 15 letters. And clearly, the Ozurdex-treated eyes here did much, much better, and they were able to get registrations in many countries, but not all. Unfortunately, Australia, but the US and Europe they're able to get registration for RVO. And of course, intraocular pressure goes up with steroids and came down again when they went on treatment. There was very little cataract progression, but you're not going to see cataract progression in a 6 or even a 12-month study. It takes 1 to 2 years before you start getting secondary cataract. So this is, again, one of our studies, a Beverdex study, but we could give it every 4 months. And this shows here the central macular thickness. Clearly, Ozurdex is wearing off at 4 months in many, many eyes. So 6-monthly dosing with Ozurdex is going to, it's not going to get the ideal outcomes that you could get if you used it more intelligently. So then Novartis ran head-to-head studies, ranibizumab versus Dex implant. They gave ranibizumab 3 monthly doses and PRN, and they give Dex implant just at baseline, and they took out the outcome at 6 months again. So he said, well, if you take out the outcome at 6 months, the Ozurdex will have worn off, and they said, well, that's the label, so that's what we're going to do. So these studies were really meant to show that the label was wrong, not that the drug didn't work. And they found here for the BRVO study that both drugs worked well at 2 months. Then the Ozurdex wore off in visual acuity here around 3 months. And again, with the central macular thickness, the Ozurdex wore off. But of course, ranibizumab treated PRN did very well. And here's the intraocular pressure peak. See the way they've got the y-axis here. It extends the entire jump, which is only actually about 4 millimeters of mercury. And the same with SEN and CRVO. Both drugs worked very well to start with, but the Ozurdex wore off at 3 months, and same with central macular thickness. So it's a head-to-head. Really, it shows that in the first couple of months they did very well, but they chose a primary, which is always going to find that ranibizumab did better than Ozurdex, but it didn't convince me. Same with the intraocular pressure. So I'd like to finish with a study from Yong Hee's group in South Korea. I think this is a very good study. It's really a real-world type study with an open-label study of patients receiving Ozurdex for a retinal vein occlusion. And these are the standard eligibility criteria. And the primary endpoint was the mean change in BA from baseline to 6 months. And you can see here that it was quite a good group to study. They had, on the bottom 2 rows here, that the mean vision was 50 letters, which is 630 or 2100, and it means they were quite swollen, about 500 microns. And here we have a very good improvement here at 1 week. There was a 10-letter improvement at the 1 week time point, which held up for the extent of the study, and they got a statistically significant improvement compared to the baseline level at 6 months. Intraocular pressure went up, it was reasonably controllable. There's quite a good graph here. So there were some eyes that peaked above 35 millimeters of mercury. It does happen with Ozurdex. This is it's at less than 5%, but it can happen. They had some eyes here in purple on triple therapy, but no eyes required to go to surgery. And you can see that the intraocular pressure medication usage was not excessive. It was only in a small proportion of patients throughout the first 12 months of the study. Mean central macular thickness, the same thing that we saw. It went down immediately, peaked at 4 months and 8 months because the drug's wearing off at 4 months. But they kept it down to quite a good level throughout the study. So the number of injections received, approximately a quarter of the eyes, or a bit over a quarter of the eyes, I got away with just 1 injection over 12 months. We had about 20% had 2, and the other half had the maximal 3 injections over the 12-month period, and the number of injections didn't correlate with any of the things, the type of macular edema, the non-perfusion, or the area of macular involvement. So in conclusion, from this study, eyes treated with BRVO had very good improvements in vision and reduction in central retinal thickness, and the safety profile was consistent with previous studies. How do I use steroids for RVO? It's pretty straightforward. If it's phakic eyes, I don't like using steroids because I don't like to have to cope with a cataract in a patient with retinal vein occlusion. As we all know, these patients tend to need, many of these patients still having treatment 2 or 3 years later. So I generally start with anti-VEGF, and I'm reluctant to switch. Maybe I'll do that after 6 to 12 injections. But if it's pseudophakic, I'm getting a sore wrist, I start straight up with steroids as first-line treatment and pseudophakics for branch retinal vein occlusion. and central retinal vein occlusion. Thank you.